our next speaker is Dr. Prakash Darji, who is going to talk on CKD management. Prakash and myself were together at IKD in 1998. After passing nephrology, he was consultant and consultant nephrologist and head at Zydus Hospital, Ahmedabad. His main interest is in CKD management and transplant immunology. He was pioneer in initiating renal transplantation in private institutes. His special interest is also Kailas mountain, and is very fond of going there, and is a very good tracker. Thank you.
Thanks, Praful. Thanks to the organizers for inviting me. My task is chronic kidney disease, scenario-based lessons for physicians. So I am going to talk on the day-to-day problems of chronic kidney disease which usually encountered by physicians. CKD, we all know it is a very huge global problem. Almost 85 crore people worldwide expected to be having chronic kidney disease. Almost like there was one data in 2017 which I could able to see, and in that data they said that almost 2.3 lakh people died in India because of chronic kidney disease. So that was the past data. Usually the chronic kidney disease is underdiagnosed globally because of the investigations which usually we are not doing for the diagnosis of chronic kidney disease. And it is likely to be a fifth leading cause of death in 2050. So that is projected. The reason of increasing the incidence of chronic kidney disease is population growth, aging, obesity, higher incidence of diabetes, particularly type 2 diabetes, hypertension, preterm birth, increasing environmental threats like infections and climate change and all. CKD is under-recognized risk factor for cardiovascular mortality. Usually like almost 2 to 3-fold rise in the cardiovascular disease if there is a chronic kidney disease. So most of the patient, like in our practice also, once the patient diagnosed having chronic kidney disease, particularly in diabetic and sometimes non-diabetic also, out of 10, 8 or 9 patients die before they require dialysis or transplant. So they die on with the journey of progression of the chronic kidney disease because of cardiovascular disease. So the cardiovascular risk factor treatment and monitoring is very important, particularly for the physicians, because you are encountering to these patients very early. Before they recognize that this is kidney problem, you can diagnose and you can prevent the CV mortality. So how to diagnose? I will present a few cases and explain the things accordingly. This is one case, 52-year-old female, medical history of hypertension and type 2 diabetes. Serum creatinine was 1.2 3 months ago, and now it is 1.4. What additional test we should perform at this stage, and how do we stage this patient? Okay. Now, according to the KDECO guideline, CKD is defined as a abnormality of the kidney structure or function. Remember, it is not kidney function. It is kidney function or structure present for a minimum 3 months with implications for health irrespective of the cause. That is chronic kidney disease. This is the definition. So chronic kidney disease, there should be reduction in the glomerular filtration rate. And how will you calculate glomerular filtration rate? It is estimated glomerular filtration rate, which we are calculating with the help of serum creatinine. So there is one like there are so many formulas which Dr. Cecil has already talked, but CKD EPI formula in which you will have to see the age, sex and serum creatinine, and it will give you the exact GFR. So this patient's GFR was less than 60 ml. What next test you will perform? Usually in this case, I will do albumin creatinine ratio. Even if the creatinine is 1.4, the most important test you will do is albumin creatinine ratio. Now this is the KDICO guideline staging. Previously, people were staged according to the GFR only. Stage means GFR more than 90, stage 1, and less than 15, stage 5. So progressively the GFR reduces, stage is increasing. But now they have added albumin also. Albumin creatinine ratio normal means less than 30 ml, A1, 30 to 300 ml, A2, and more than 300 milligram, it is A3. So suppose if there is GFR of 40, stage 3, and if albumin is 300, stage 3, A2. So that will be the staging of the chronic kidney disease. Now, what is the importance of this? If the staging is increased, the chances of risk is also increasing. So in red, it is very high risk, it is high risk, it is mild or moderate, mild risk, and normal. Okay? Now, high albumin creatinine ratio, what is the meaning of that? It means that there is endothelial injury, and that causes microvascular damage. Some early CKD patients may show elevated albumin creatinine ratio without reduction in the GFR. So even if there is normal GFR, if there is albumin creatinine ratio altered, there is significance of that. So risk stratification is to be done on the basis of GFR as well as albumin creatinine ratio. And KDOCI guideline is also involved this. In our patients, albumin creatinine ratio was 148. So this is G3A2. So even if there is normal albumin, see, if we see the renal progression, if there is normal GFR, the progression risk is less. But if we see the stroke, if we see the myocardial infarction, if we see the cardiovascular mortality is significantly high, even if there is normal GFR. If the albumin is high, the risk of cardiovascular means CV mortality is all high. Okay? Now another case, 26-year-old male patient, national level heavy champion, heavyweight champion lifting, no comorbidities. On regular checkup, he found to have creatinine of 1.7 and GFR of 56. Went alternative medicine and diet control for his high creatinine. He lost 10 kg weight. We also encountered such kind of patient. They go for alternative medicine and they lost a lot of weight. His creatinine from 1.7 to 1.4 and his eGFR was 80. What happened? His GFR is improved, or what is another method, or what is the correct method of measuring eGFR? We are measuring eGFR with the help of creatinine, but creatinine generation and tubular excretion condition can be different. So if there is low creatinine generation, because creatinine generates from the muscle mass. If the muscle mass is reduced, the creatinine generation is reduced. So you might have reduction in the creatinine, but GFR might be low. So there are certain conditions which alters creatinine level, and that alters GFR also. So we have to think all these things in our mind. So in such case, we have to see the cystatin C, and cystatin C GFR is very important. So cystatin C is hardly changed with certain lifestyle changes or body composition or certain medicines. So cystatin C, if there is abnormal creatinine or if there is sudden change in the creatinine, we have to see cystatin C to exactly calculate the GFR. And now KDOCI has also incorporated cystatin C as a cystatin C eGFR. So how will you manage these early CKD patients? Simple, treatment of reversible cause if there is. Suppose if patient is taking NSAIDs or any other nephrotoxic drug, you have to avoid. Prevent and slowing down the progression of chronic kidney disease and prevention of the CV risk or reduction in the CV risk. Adequate monitoring of the patients and identification and preparation of the patient in need of renal replacement therapy. If suppose patient is progressing to ESRD, we have to maintain him properly so that treatment of ESRD is become easy. And for that, combined approach with physicians and multidisciplinary team is required. The major component of the treatment is BP control, diabetes control, and management of other comorbidities and other drugs and side effects. Another case, 48-year-old male, medical history of hypertension, diagnosed 2 years back, CKD diagnosed 6 months back. So he's already diagnosed case of CKD. Most recent GFR is 57, so it is G3, eGFR 57. He manages hypertension with the help of low sodium diet and exercise. His blood pressure is 128/76 average, and his standardized blood pressure at clinic was 130/78. His today's urine albumin creatinine ratio is 60 milligrams, so it is A2, it is medium risk. Given his kidney disease and cardiovascular risk, what would be the appropriate step for the management of this patient? What will you do? Whether you will ask him to continue no medicine, just exercise, or you will add something else. Now, KDIGO guidelines says that the target blood pressure should be less than 20, but it is just a recommendation. It is encouraged to individualize the blood pressure target accordingly. Suppose if the patient is elderly, by reducing blood pressure very low, or if there is stroke, ischemic stroke, and if you will reduce blood pressure to very low, less than 120, it may cause some increase in the symptoms. But usually the KDOK guidelines says that the CKD patient should be kept less than 120 systolic blood pressure for reduction in the progression also and for CV mortality also. So lifestyle modification is okay, but if you want to control blood pressure, it is better to start with either ACE inhibitor or ARB. So even if there is 130 blood pressure, if there is albuminuria A2 with or without even CKD, means GFR normal, you should start with ACE inhibitor or ARB. In our patient, we started with either ACE inhibitor or ARB. If the blood pressure is not controlled, if there is hypertension, you can add any other antihypertensive after optimization of one drug. Okay, but never add ACE inhibitor to ARB. So don't prescribe both the drugs together. Check creatinine and potassium after 2 weeks of starting ACE inhibitor or ARB. Avoid NSAIDs, and ambulatory blood pressure or home blood pressure monitoring is promoted because that is the best thing to see the blood pressure. Another case, 55-year-old male, medical history of type 2 diabetes, hypertension and CKD, stage G3. So GFR was like less than 60 to up to 30 ml. And albuminuria is more than 300. So it is A3, G3, A3. He is found to have uncontrolled blood pressure on office and home BP monitoring with. He was on low sodium diet, exercise plan, losartan. He is already on losartan, chlorthalidone and amlodipine. So these things he is already doing, and still his blood pressure is on the higher side. Creatinine is 1.6, potassium is 4.9, albumin is 1100. At this point, we decided to double the dose of losartan. So we made losartan 100 milligram. After 2 weeks, creatinine is 1.8, potassium is 5.4, and urine albumin creatinine ratio is 500 milligrams. So albumin is reduced, but creatinine is increased and potassium is increased. Now what to do? Whether to go to another, like same point, means from 100 milligram to 50 milligram losartan, or to stop losartan, or what to do? Why there is hyperkalemia in this patient? Because maybe because of high potassium diet, or impaired renal function, or type 4 RTA, heart failure, concurrent potassium sparing diuretic, and potassium supplement. So it is better to see all this. Use of ACE inhibitor or ARB is associated with elevation of the creatinine is also, it is very well known, because it reduces intraglomerular pressure, and because of intraglomerular pressure reduction, it causes decrease in the GFR, mild decrease in the GFR, and that can cause little bit rise in the creatinine. So now it is recent guidelines says continue ACE inhibitor and ARB unless if there is rise in creatinine is more than 30%, or symptomatic hypotension, or hyperkalemia remains uncontrolled despite medical treatment. So try to control potassium with medical treatment. Or uremic symptoms develops while treating. Suppose sometimes there is bilateral renovascular disease. If there is ischemic kidney, and if you start ACE inhibitor and ARB, ACE inhibitor or ARB, the chances of getting acute kidney injury is high. So there may be sudden rise of creatinine, means sudden fall of the GFR more than 30%. In that case, you have to stop ACE inhibitor and or ARB, and you have to evaluate for that. So you can go for Doppler and further study. Strategies to improve. We know how to improve potassium. There are certain potassium resins available. If there is dietary potassium restrictions and other drugs which causes potassium is not. Suppose if the patient is on spironolactone, it is better to stop spironolactone. So two drugs together, means ACE inhibitor or ARB, or ACE inhibitor ARB plus ACE inhibitor or spironolactone can cause, means potassium sparing diuretic can cause significant hyperkalemia. So it is better to avoid all these things and see if potassium gets corrected. Because discontinuation of the ACE inhibitor or ARB is high risk, it causes high risk mortality for CV disease, means patient is high risk for CV mortality if you stop ACE inhibitor or ARB. So it is better to continue these medicines. Last case, 57-year-old female, medical history of diabetes, hypertension, coronary artery disease, and CKD, stage G3, A3. Comes to clinic with long-lasting uncontrolled diabetes, complicated diabetic retinopathy, and despite of metformin, his diabetes is not on control. His blood pressure is okay, 128/78. She is on lisinopril and atorvastatin also. She is euvolemic. Her creatinine is 1.8. Serum potassium is 5.2 with ACE inhibitor. Bicarbonate is 26. GFR is around 44, and proteinuria is significantly high. Which is the another drugs to add to reduce progression of the disease as well as to reduce CV mortality. So beyond ACE inhibitor ARB, there are growing list of the drugs. These are recommended to be used in a patient with moderate to severe albuminuria. The most important drug which is nowadays hot favorite is SGLT2 inhibitors. There are certain other drugs like GLP-1 receptor agonist or non-steroidal mineralocorticoid antagonist. SGLT2 inhibitors reduces sodium and glucose reabsorption from the proximal tubules, and by that it affects the juxtaglomerular feedback mechanism, and it causes intraglomerular pressure. So this is definitely causing reduction in the renal injury with the help of this medicine. There are 3 landmark studies and credences for diabetic, and these 2 are diabetic plus non-diabetic. All has more than 4,000 sample size and more than 2 to 2.5 years of follow-up. All these studies says that there is reduction in the progression of the kidney disease. So this is very important. We need to have a drug which reduces the progression of the CKD. And all these drugs reduces CV mortality also. All these drugs reduces hospitalization also. So it is fantastic medicine. It is to be used in a patient in such kind of. So KDOCI also recommends this medicine in diabetes with CKD regardless of the glycemic control, because it doesn't cause hypoglycemia. It causes normoglycemia but doesn't hypoglycemia. GFR more than 20 ml should be there, and concurrent albuminuria is more than 200 milligram. CKD and heart failure regardless of the albuminuria. If there is heart failure with CKD, even if there is, and nowadays cardiologists use, even if there is no CKD, only heart failure, they are using this medicine. And guideline also says that first line therapy for the patient diabetic with CKD first line therapy for diabetic patients with CKD on statins, RAS inhibitor, metformin and SGLT2 inhibitor. So these are the medicines to be routinely given. In our patient, we used SGLT2 inhibitors to control the proteinuria. Now, this is the issue. This is the dark side of the medicine. SGLT2 inhibitors, if there is any patient who is having lower urinary tract symptoms, urinary tract infection, any history of urinary tract infection, stone disease, please be cautious, because it reduces the absorption of the glucose from the proximal tubule, so it increases the availability of the glucose in the urine, and that causes urosepsis. This patient is having abscess, ruptured, after giving SGLT2 inhibitors 4 weeks, and he has history of stones also. So if there is history of stone disease, or if there is any intervention, this patient has gone for urinary intervention because of bilateral ureteric obstruction. The surgeon did bilateral URS and degestanting. After 1 week, he came with bilateral renal abscesses. So this is the dangerous, and this is the recent 13th April 2025, 10 days back. So this is the issue. Another thing to manage, last slides, in patient with diabetes and CKD with uncontrolled albuminuria, despite of ACE inhibitor, ARB and SGLT2, what is to be done? Another medicine, fildenone. So this can be utilized, and it causes further reduction in the proteinuria and CV event, provided potassium is normal. It can, like industry says that it doesn't cause hyperkalemia, but it can, like we have seen few of the hyperkalemia after using this molecule, but it is one of the drug can be utilized. To summarize my talk, stage the CKD according to the GFR as well as level of albuminuria, not only GFR, see the level of albuminuria. This is very important. High urinary albumin suggests endothelial injury, dysfunction, and it causes CV mortality. Physicians play crucial role of early detection and management of CKD, which does not only reduce CKD progression, but helps in cardiovascular health. Thank you.